Divya, you are mute.
So we are live. We are live. We are live.
Yes, sir.
Okay. On behalf of Indian Academy of Neurology Movement Disorder Subsection, I welcome everyone. And we are going to conduct this program on the eve of World Movement Disorder Day, which was celebrated on 29th of November all over the world. And the focus of the program of this year was removing the stigma of movement disorders. Movement disorder, different types of movement disorders have different stigma in the society. And this stigma is increasing as we are learning more and more about movement disorders. Going forward, I welcome our secretary and convener of movement disorder subsection, Dr. Ravi Yadav, who is professor neurology at NIMHANS, Bangalore. He is also currently secretary of Indian Movement Disorder Society of India. Welcome, Ravi, and you can take the proceeding forward.
Thank you, Dr. Sanjay, for your kind introduction. As Dr. Sanjay has pointed out, World Movement Disorder Day actually began only, I think, last year or last year. And it just highlights the importance of movement disorders, awareness that has to be created in the society, especially in India, because many of the disorders the awareness is very low in our country. So in extension to that, and going by the aims and objectives of Indian Academy of Neurology Movement Disorder subsection, we have this program to raise the awareness about the movement disorders. And in this line, I would like to invite Dr. Sangeeta Rawat, IN President, to give her comments, and Dr. Meenakshi Sundaram, Honorary Secretary, Indian Academy of Neurology, to give his comments. Have they joined?
No, sir.
Okay. Okay, then we will continue with the program and see when they join, they can definitely give the comments. So now I would like to invite our young volunteers, Dr. Divya and Dr. Neeraj Kumar. Dr. Neeraj Kumar is a professor of neurology and an HOD of neurology at AIIMS BB Nagar in Hyderabad. And Dr. Divya is additional professor of neurology and at Sri Chitra Tirunal Institute in Trivandrum. Both are experts in movement disorders and have volunteered to conduct this program. So I invite Dr. Neeraj and Dr. Divya to take over the program and conduct it. Thank you so much.
Thank you, Ravi boss. So thank you for the opportunity. And today the theme of the program which we have prepared is basically based on movement disorders and how a physician should approach movement disorders. Because although it is the movement disorder experts and neurologists who are taking care, but then there are a lot of patients which are being dealt initially by physicians. So that is the theme which we are taking forward. And my co-host, Dr. Divya, she will start the program. I request her to kindly invite the first speaker, and straight away we can go ahead. Divya, please.
We'll be going through quickly through 4 talks and 1 panel discussion. So for the first talk, it's on what are movement disorders, which will be delivered by Dr. Sahil Mehta. Dr. Sahil Mehta is the additional professor, Department of Neurology at PGI Chandigarh. His areas of interest are botulinum toxin, focal dystonia, and rare movement disorders. He has over 90 publications and he has multiple major achievements, especially he is the assistant editor of Annals of Movement Disorder. He has contributed to one of the largest series of Plateau G6 published from India in movement disorders. And he's also a member of the International MDSI as well as the International MDS Society. Over to Dr. Sahil for his talk.
Thank you, Dr. Divya, for the kind introduction. At the outset, I would like to thank IN Movement Disorder Subsection for giving me this opportunity. So what I will do in the next 10 minutes, I will just give a brief overview of the various types of movement disorders which we encounter for the general physicians. So what are movement disorders? Movement disorders are basically, these are the disorders which affect the bodily motor control, and these occur due to the dysfunction at the level of the basal ganglia. So these can be classified as hyperkinetic and hypokinetic movement disorders. Hypokinetic when there is paucity of the movement or the slowness of the movements, and hyperkinetic when there are excess or too fast movements. So hypokinetic movements are basically mainly the Parkinsonian syndromes, or as we call as akinetic rigid syndromes. And the hyperkinetic movements, they encompass a variety of disorders ranging from chorea, dystonia, tics, myoclonus, stereotypies, and tremors. Dr. Divya, can you show the slides, please?
Yeah, I'm moving the slides. Can you see
Okay.
them? Oh,
Okay.
just
Yeah. Thank you.
Okay.
So firstly, coming on to Parkinsonism, the Parkinsonism syndrome can be memorized by the mnemonic trap, which encompasses tremor, R for rigidity, A for akinesia or bradykinesia, and P is for postural disturbances or gait dysfunction. Out of these, bradykinesia, which is defined as slowness of the movement, and more specifically, the decrement in the amplitude of the movements when we ask the patient to do repetitive motor tasks, is the most cardinal feature. And the recent MDS criteria have included bradykinesia along with either tremor or rigidity as one of the diagnostic criteria for Parkinsonism. So there can be a variety of causes of Parkinsonism, ranging from acquired causes like infections, drugs, toxins, metabolic causes, structural causes like tumors, SDH, vascular, and a host of degenerative disorders, the most common being the idiopathic Parkinson's disease and other atypical Parkinsonian disorders. Various other hereditodegenerative disorders can also have Parkinsonism as a predominant manifestation. So coming on to the red flags. So when we encounter a patient of Parkinsonism and we have these red flags, it takes us away from a diagnosis of idiopathic Parkinson's disease and favor more of an atypical Parkinsonian disorder like PSP or multiple system atrophy. These include rapid progression, early bulbar dysfunction, inspiratory stridor, severe autonomic dysfunction in the first 5 years of disease, recurrent falls in the first 2 years which favor PSP, disproportionate enterocollis or retrocollis, unexplained pyramidal signs, and bilateral symmetrical Parkinsonism, as idiopathic Parkinson's disease is largely an asymmetrical disorder. Next. So these are the two examples of patients. On your left is the patient of classical Parkinson's disease, which has asymmetrical tremor and rigidity mainly affecting the right side. You can also observe mask-like faces, decreased blink rate. And what I am testing here is the bradykinesia. When I'm asking him to do repetitive finger tapping, there, as you can see, there is decrement in the amplitude of the movement. And it is more on the right side compared to the left side. And kindly note the classical resting tremor, which is seen in PD. Vis-a-vis on the right is the patient of PSP who needs almost double support for his ambulation. There is classical retrocollis occurring. And as you can see, there will be classical eye movement abnormalities, which will be documented later in the video. The gait is short steppage, wide base gait. In Parkinson's disease, usually the gait is narrow base, but in atypical Parkinsonian disorders, you can have wide base gait. And the cardinal feature of progressive supranuclear palsy is the eye movement abnormalities with classical vertical gaze palsy. This is mainly an advanced stage of PSP, with both horizontal as well as vertical restriction. But in early stages of PSP, you can just have a vertical gaze palsy. His all eyes are almost frozen. Coming on to the next type of movement disorder, which is dystonia. And it is defined as a movement disorder which is characterized by sustained or intermittent muscle contractions leading on to abnormal postures or movements, and they are typically patterned. And the tremor can be a part and parcel of dystonic syndrome. And basically, we have certain characteristic features which favor a diagnosis of dystonia. These include they are precipitated by voluntary action. Presence of sensory or, as you know, as gesture antagonist is a very cardinal feature of dystonia. And then you can have mirror movements and other features like overflow and dystonic tremor. Recently, now we defined the dystonic syndrome on the basis of two axes. Axis 1 mainly includes the clinical features, and axis 2 is mainly based on etiology. The clinical features include, depending upon the age of onset, whether the syndrome is isolated or combined, whether they are associated other movement disorders or other systemic signs and symptoms, and we can define a dystonia syndrome and find out the etiology accordingly. Next slide, please. Next. So these are certain examples of patients with dystonia. The first one is a patient developing extensor truncal dystonia with opisthotonus and retrocollis, with also the internal rotation at the level of the shoulders. Basically, mainly a segmental dystonia. Then the second figure, you can see forceful contraction of the eyes, and this is a feature of blepharospasm, and the patient is using sensory trick to open the eyes. And the third is the patient of cervical dystonia with the torticollis to the right side, and is also using mainly a sensory trick to decrease his dystonic movements. Next. These are more examples. The first one is an example of writer's cramp. Whenever you write, you can see the index finger goes into the extensor posturing, and this is extensor type of writer's cramp. And then the next video is a patient of spasmodic dysphonia. You can observe the strained quality of the voice, which is suggestive of adductor dysphonia. The third video shows a patient of foot dystonia, predominantly involving the inversion and plantiflexion of the right foot whenever he walks. And the last patient is of feeding dystonia, which is a classical feature of neuroacanthocytosis. Next. These are just snapshots of the various types of cervical dystonia, ranging from torticollis, laterocollis, retrocollis, enterocollis. These can occur in various combinations. Next. Now, coming on to the tremor. Tremor is defined as the rhythmic oscillatory movement of a body part along an axis, and this occurs due to the contractions of the reciprocally innervated muscles. And the tremor can be differentiated on the basis mainly because of the activating conditions, whether it is occurring at rest, whether it is occurring with posture or as a kinetic tremor, that is called as action tremor. And then again, this will also be differentiated on the basis of axis 1 as clinical features and axis 2 as etiology. Next. So this was an initial classification when we used to define the tremors based on frequency. But nowadays, mainly we use the activating conditions and to find out what precipitates the tremor, and we find out the etiology and approach the patient accordingly. Next. So these are the examples of, on the left is the example of essential tremor, which is predominantly an action tremor more than postural tremor. This patient slightly advanced and the tremor is occurring at rest also, but it is predominantly action tremor, bilaterally symmetrical, more than 3 years duration. And you can see the predominant action tremor when we ask the patient to pour the water in the glass. And to differentiate from the re-emergent tremor of PD, this is the second example. And the difference basically is when we ask the patient to outstretch his hands, the essential tremor, the tremor occurs almost instantaneously whenever the patient assumes the outstretched posture. But in the re-emergent tremor of Parkinson's disease, usually there's a latency of almost 5 to 10 seconds before the tremor appears. Next. These are the other examples of tremors. On the left is an example of dystonic tremor, mainly affecting the left hand. You can observe the abnormal posture of the left hand along with the tremor, which is a slow tremor. And the right side is a patient with a midbrain AVM who had features of rubral tremor. Again, a low frequency tremor occurring in all the positions, rest, postural, as well as intentional and a kinetic component. Next. So coming on to the chorea, chorea is an involuntary movement disorder, which is mainly described as semi-purposive, and the flowing movements which flow from one part of the body to another. The random movements, random muscle groups are affected. And the cardinal example we all know is the Huntington's disease. And next slide, please. So this is a patient of Huntington's disease who had a chronic progressive chorea with positive family history. You can see the random flowing movements. And on the right side is a patient of most common drug-induced chorea, levodopa-induced in a patient of Parkinson's disease with peak dose dyskinesia. Next, please. Next. And when the choreoform movement, they become so strong and they almost involve the proximal joints, almost violent clinging-like movement that is called as bellism. And this is an example of hemichorea, hemiballism in a patient with hyperglycemia. And with classical, her MRI showed classical T1 hyperintensities in the contralateral basal ganglia. Myoclonus are brief shock-like muscle contractions in this patient who presented with predominantly cortical myoclonus. And the myoclonus can be classified on the basis of the origin. It can be cortical, subcortical, segmental, proptospinal, and then there are other classifications also. Peripheral form of myoclonus is the hemifacial spasm. In this patient, you can see the involuntary contractions of the left side of the face, which is called as hemifacial spasm. And coming on to the tics, these are usually repetitive movements occurring in a child. They can have motor tics or they can have vocal tics. And when they have a prolonged duration, more than 1 year duration, and with the next slide, please. And this is a patient who was of Tourette syndrome who had multiple motor tics as well as vocal tics in the form of eye blinking, shoulder shrugging, neck movements. Usually these patients have a premonitory urge and they can partly suppress these movements. Stereotypies are the also movements. This is as if the same video is playing again and again. This was a patient of Wilson's disease who had these left leg stereotypic movements. And finally, the functional movement disorders. Usually nowadays, the diagnosis is mainly based on positive phenomenon. When you have a variable movement disorder, when the patient is distractible, or the inconsistent, the positive phenomenon of entrainment. Like in this patient, there was a suggestion because of give way weakness at the knees, and she was distractible. Next. And this was a patient of palatal tremor. And when there's oculopalatal tremor, the lesion is usually in the angle, but in this patient was only this synchronous movements of the soft palatal tremor, which nowadays is being considered even of functional etiology. And lastly, drug-induced movement disorder should never be missed. The first one is a patient of phenytoin-induced both positive as well as negative myoclonus. And the second one was when the patient was taking levosulfuride, she has these orolingual movements called as orobuccolingual stereotypies. And lastly, was a patient referred from psychiatry who was on typical antipsychotic, and she presented with symmetrical Parkinsonism responsible because of dopamine blocking action. So I've just shown a brief overview of various types of movements, both hypokinetic and hyperkinetic. I hope this would have benefited the general physicians. Thank you.
Thank you. Thank you, Sahil. It was an excellent presentation with very nice videos. And I'm sure it must have cleared a lot of doubts. And thanks a lot, Sahil. So we move on to the next talk. And we will have Dr. Lulup Sahu. Dr. Lulup Sahu is currently professor in neurology at some hospital, IMS and some hospital in Odisha. And he has several publications, but I think the recent achievement which he had is a nice one, that he has started the deep brain stimulation at 2 centers in Odisha is doing that. One is Dr. Lulup and the other, of course, is AIIMS Bhubaneswar. So Lulup will be speaking on diagnosis of movement disorders. So Lulup, please go ahead and start your talk.
Thank you, Neeraj sir, for your kind introduction. So my topic of discussion is diagnosis of movement disorder. So already described by Dr. Sahil that movement disorder is basically the diagnosis, clinical diagnosis and examination wise. But the phenomenology of the movement, those are the usually have a significant thing in the diagnosis of all the movement disorders. So usual diagnosis of movement usually based on phenomenology of the movements, what the type of movements patient is having, whether it is a hypokinetic movement or hyperkinetic movement. If any movement is there, whether those movements are associated with any other systemic features like cave ring, any skin changes, any telangiectasis, any facial dysmorphism, any organomegaly, those usually helps us in diagnosing a movement disorder. And usually sometimes like in ataxia telangiectasia, if you're getting a young boy with ataxia and telangiectasia in the eyes, then diagnosis is clear cut. You need not go for genetic testing also. If cave ring they are visible in the naked eye, also can be seen in street lamp examination, then your diagnosis is very easy for Wilson disease. And for that only organomegaly, for any metabolic disorder, any storage disorder, usually very helpful in diagnosing a movement disorder in particularly. And sometimes usually for classical Parkinson, you may not need any investigation because it is a clear-cut clinical diagnosis. Sometimes if at all it is required, you can go for DAT scan and all, but it's purely clinical-based diagnosis. Brain imaging is not essential in all patients of movement, but sometimes if patient is young, very young and having any form of movement, there may be hypokinetic or hyperkinetic. You have to rule out Wilson disease by MRI and other investigation and copper study and all. Other parameters like EEG, NCS, somewhat sensory evert potential are also helpful in reaching at a particular diagnosis like in PME syndrome, in SSP, and in NCS in neuroacanthocytosis. Those are very helpful in diagnosing. And other metabolic parameters like organic aciduria, IM panel, those are helpful in some inherited metabolic disorder. And finally, genetic testing, we have a dilemma and some family history there, we can go ahead with genetic testing. And genetic testing is not the final diagnosis. Sometimes genetic testing may be negative also. Till if you have other parameters and clinical phenology, then we can reach a diagnosis. Come to the case presentation. Sorry, are my slides moving?
No, Lulup.
Yeah. Okay. So this is the criteria already described by Dr. Sahil. So this is PD criteria by MDS clinical diagnostic criteria. So for this essential criteria is the bradykinesia. If along with at least rest rigidity, and bradykinesia is the sign qua non for diagnosis of Parkinsonism. If it is not there, then it is not Parkinsonism. Then for telling Parkinson disease, we have two other red flags that they are already described. Dr. Sahil, I'm not going in detail. Like wheelchair bound, absence of any progression, absence of non-motor symptoms, frequent falls. If those red flags should be absent for telling it a Parkinson disease. But again, other supportive features, if they are like significant response to levodopa, at least in EPDRS, if you're getting more than 30% improvement in the patient scoring, then you can call it Parkinson disease also. And or after stopping medication, if you're getting any deterioration on the clinical parameters. This other Parkinson feature you can see while patient is getting up from chair, patient is having backward fall. This is classical called as rocket sign seen in progressive supranuclear palsy. And in these cases, if you are getting MRI, you can see there is a hummingbird sign, and also there is morning glory sign, which helps in diagnosing your PSP patient. Also, volumetric analysis of the midbrain area also can be helpful in diagnostic criteria of PSP patients. This elderly patient, again, 7-year-old patient with walking difficulty with forgetfulness and urinary urgency. And while walking, you can see there is a patient walking very short steps with wide base and foot as if it glued to the ground. So this is the classical magnetic gait of lower body Parkinsonism. In these cases, if you are seeing this type of presentation, you can straight ahead go ahead with the imaging part. If you are getting hydrocephalus features, then you can suspect normal pressure hydrocephalus. And doing a therapeutic LP drainage of 40 to 50 ml, if there is significant response in the gait part, then we can call it NPS. Otherwise, close mimic at the vascular Parkinsonism also. But all the tremors are not Parkinsonism. So it may be due to this lady. You can see there is fine jerky tremor in the both upper limb, and there is ectothalmus you can see, and her examination thyroid profile is there is thyrotoxicosis there. So this is thyrotoxicosis with the tremor. So all the tremor are not Parkinsonism. We have to see for whether bradykinase is there or not there. Come to the other lady, 25-year-old lady, who is present, known case of diabetes, who presented with involuntary movement of the right upper limb, lower limb in form of right hemisphere. So after on examination, there is RBS was very high, almost 350, and in the MRI you can see there is flare hyperintension in the left basal ganglia. So this is a diabetic steatopathy. But this other lady, which is not a non diabetic mellitus, but present with generalized chorea with short history, 1 month history of generalized chorea. So in this case also, though it is a generalized chorea, you should suspect a diabetic steatopathy. And CT, you can see there is bilateral basal ganglia changes are there, and RBS is 470. So this is a newly detected diabetes mellitus present with generalized chorea as part of diabetic steatopathy. Come to the next one. This 30-year-old man present with abnormal movements of generalized upper limb and lower limb with feeding difficulty. And you can see there is orobucofacial lingual disc and chorea is there, and also having feeding dystonia. So this is the case of suspected neuroacanthocytosis. So in that case, you can straight ahead go ahead with the common peripheral smear. And fresh smear is usually very significant in seeing these acanthocytes. So in the slide, you can see there are acanthocytes are there. And imaging, you can see the MRI showing there is caudate atrophy bilaterally, and which is feature of neuroacanthocytosis. This type of caudate atrophy with Boss scar ventricles also can be seen in Huntington disease patients also. This is the other boy. You can see 20-year-old boy with posturing of the both upper limb, lower limb with dystonia. So this is a young onset of dystonia, generalized dystonia with lower limb involvement. So in this case, you have to see for any cave ring is there or not there. So here in the image, you can see there is a presence of cave ring is there. So cave ring is there, you can see in the images. So it suggests a Wilson disease, and the MRI shows a brainstem changes in the MRI. So this is serum ceruloplasmin you have to send, which is very low, and 24-hour urinary copper is very high. So this is case of Wilson disease. Don't miss a Wilson disease patient in young onset of any movement. It may be hypokinetic or hyperkinetic movement disorder. Come to this other boy, 2-year boy who had a normal birth history and normal development up to 2 years of age. When he developed a febrile illness followed by this type of dystonic spasm, general dystonia with optic stonus posturing with status dystonicus, followed by developmental regression. In the MRI, you can see there is T1 weighted hyperintensity seen in the bilateral basal ganglia in the brainstem region. So when you're seeing this type of hyperintense changes, you suspect hypermagnesemia. So in this case, the manganese level is very high. So this is a case of hypermagnesemia with dystonia type 2, because he had also polycythemia and some organomegaly were there and genetical proven. This other girl you can see having a general dystonia with oromandibular pedon dystonia in form of jaw opening dystonia, and MRI shows a eye of tiger appearance. So when you're seeing this type of MRI images, the diagnosis is clear-cut pecan variety of NBIA. This other lady, 25-year-old lady, presented with imbalance while walking and jars in both upper limb. So in the video, you can see there is axon myoclonus present in both upper limb with impaired finger nose taste. And while walking also, patient having ataxia gait, wide-based ataxia gait. So if you're seeing a young patient with ataxia and myoclonus, always see for the fundoscopy to see for cherry-red spot. In this patient, you can see there is a bilateral cherry-red spot is there. And if you're getting cherry-red spot, your diagnosis is very narrowed down to sialidosis. So this is classical finding. When you're finding this one, you can straight ahead go into the diagnosis part. This other boy who had a short history of cognitive decline with slowness of activities along with jerky movement of the both upper limb. You can see there is jerky myoclonus is happening with the slow myoclonus. So if you're seeing this type of slow myoclonus, then always do a EEG to see for periodic sharp wave complexes. So this is seen in the EEG, and same for a CSF anti-meningeal antibody, which is elevated in this patient. So this is a case of SSP, subacute slurring panencephalitis. So you can have a diagnosis without antibody also if having typical slow myoclonus along with periodic sharp wave complexes. This other boy, you can see after febrile illness, he developed jerky movement of the body and with blurring of vision. You can see in the video there is opsoclonus is happening. So if you're seeing this type of opsoclonus, usually it is associated with scrub typhus. So this patient had scrub typhus for, leading to opsoclonus myoclonus syndrome. The other sometimes some patient child used to have normal development and subsequently developed dystonic posture in both upper limb, lower limb following a febrile illness. So here you can see general dystonia. So in this case, if you're seeing imaging like this, this is called classical battering appearance due to dilated bilateral sylvian fissure. So this classical feature is for glutaric aciduria. So you have to send for urinary organic acids by liquid gas chromatography, and also IM panel by TMS you can send to see for this glutaric aciduria, because this can be diet restriction. You can treat these patients for or treatment also can lead to diagnosis also. Like in this boy, you can see who have a episodic posturing of the both upper and lower limb. So after jumping for some time, you can see there is posturing of both upper limb and lower limb is there. So this is classical case of paroxysmal kinesogenic dyskinesia. So if some patient is telling this type of history, so don't always jump ahead with the seizure part. Always try to see those movements. And if you're seeing this type of movements, straight ahead give one trial of carbamazepine. Now after carbamazepine, there is patient used to have significant response to the movements. So this is PKD. And also if you're going ahead with the genetic also, you will get the mutation pattern. The other diagnosis part, treatment part leading to diagnosis is this boy you can see having a delayed milestone and diagnosed as a cerebral palsy with oculogary crisis. And after giving medication, there is alertness is improved. Patient has some mobility in the lower limb also, and some dyskinesia is happening. So the medication is given as the levodopa. So this is a dopa responsive dystonia. This is a TH deficiency which is present with the progressive encephalopathy with Parkinsonism. So this is the treatment response can lead to a diagnosis part. The DIT5 is first discovered by Segoa. This childhood onset and initial symptom is the leg dystonia, and it starts with the leg, and patients used to have a diurnal fluctuation with improvement after sleep. So the characteristic feature of the DRD is the dramatic and sustained response to levodopa without any complication. So this is a classical feature of DIT5 dystonia, DIT5 dopa responsive dystonia. So any childhood of dystonia, you have to give a trial of levodopa. So sometimes also some genetic dystonia can be assessed and from the pattern of involvement. Like in DIT1, usually it ascends up. It starts from the foot dystonia and it ascends up to involve the trunk and upper limb. But in DIT6 or thigh dystonia, usually it starts from the craniocervical region and descends down. So in this pattern also with the genetic also, you can suspect which pattern of genetic dystonia it may be. So coming to the last slide, this is a young female patient with new onset of seizure with status epilepticus with psychosis followed by alternative sensorium. And in the ICU, you can see there is perioral movement there with orofacial dyskinesia. So whenever with this typically you are seeing this type of movements, so this you have to think of autoimmune encephalitis. So for that, in one simple EEG will be very helpful. In the EEG, you can see this pattern is called extreme delta burst. Delta waves are burst with the beta activity. So this extreme delta burst, if you are finding, then always send for autoimmune panel, and it was positive for NMDA. So this NMD autoimmune encephalitis with orofacial dyskinesia. So take-home message, history and clinical examination are most important in diagnosis of movement disorders. All childhood and young onset movement patient should be evaluated with couple study to rule out Wilson disease. And all childhood onset dystonia may be given an adequate trial of levodopa to rule out any dopa responsive dystonia. Thank you. Thank you all.
Thank you, Lulu, for that excellent presentation. So, the physicians and the psychiatrists are the first doctors to see the patient with movement disorder. Hence, to emphasize the role of the physician in movement disorder management, I call upon Dr. Vaibhav Mathur to give his talk.
Dr. Divya.
Vaibhav Mathur is a consultant neurophysician and movement disorder specialist at Narayana Multi-Speciality Hospital, Rajasthan. His areas of interest are Parkinsonism and movement disorders, pharmacotherapy of advanced cases and botulinum toxin injections, and deep brain stimulation planning and programming for movement disorders. So he has multiple achievements. Over to you, Dr. Webb.
Thank you, madam. Very good evening. Can I share my screen now?
Yes, now you can share.
So we have all been here. First of all, thanks a lot to Neeraj sir and Divya madam for giving us the opportunity, and to IAN for organizing this meet for the physicians. So greetings to all the listeners. We are celebrating World Movement Disorders Day, and I'm sincerely thankful for this invitation. I'm presently working as a movement disorder specialist in Jaipur. So my topic given to me is role of a physician in movement disorder management. So I have kept my outline as the first encounter when a physician sees an abnormally moving patient, then a focused history that makes him near to the takes him near to the diagnosis, the basic workup that a physician can do for common etiologies, the gross classification that we can do for the phenomenology, and the basic treatment that can be offered, common side effects of the drug used, which is very, very important, and then counseling and prognostication of patients, and possibly if referral of for patient care, and that I think my speakers after me will cover. So the first encounter, we all know that the physician OPD is loaded with varieties like diabetes, hypertension, CLD, CKD, pain, fever patients. So encountering a movement disorder might shake the head for once. So the best way to start, as always, is the history. So asking the patient about the onset of the symptoms and progressor of the illness is of utmost importance. For example, a very acute cause of a movement disorder can be metabolic, vascular, infectious, and psychogenic. These are the most four common categories that a movement disorder in an acute form arises. This is a very common thing that I think all of us have seen in practice. This is called negative myoclonus or hysterexis. So this is an acute form where the patient presents with these kind of movements just for the last 2 days. The first two things that we need to check is hepatic encephalopathy and uremic encaph. But surprisingly, this patient had hyperglycemia. So this was a hyperglycemia-induced hysterexis. And the next day, when the sugar was corrected from 540 to 200, the patient became pretty okay. So acute movement disorders, you have to look for metabolic causes. The basic workups like RBS, ABG, and others can give you a hint. Medicine would be insulin in this case. So an early management can help you manage this case. The phenomenologies have been discussed by Dr. Sahil already. This is a very easily diagnosable thing where we have a focal movement disorder. So whenever you find a focus, for example, only one hand is moving, or there is a hemibalismus or a hemichoria, this is should be based on then MRI. You can have a structural cause for these. So we already discussed diabetic steatopathy, but basal ganglia strokes are something that we need to rule out. And stroke locations for these movement disorders can be caudate, putamen, thalamus. And in this case, this was a case report where we saw a parietal lobe infarct presenting with hemiballismus. So again, management by a physician would have been just an aspirin to start off and tetrabenazine for these movements, and we could have got the patient better. A very similar patient with acute onset facial twitching, if you can see. If the voice is audible, the patient has ataxic speech and a lot of facial twitching, facial myoclonus. This patient was found to have tick bite on examination, and the patient had scrub typhus. So acutely, infections can present as movement disorders. We have seen a lot of movement disorders with dengue encephalitis and scrub typhus, and then medicine would become ceftriaxone and doxycycline. So another case where this young boy has these abnormal purposeless movements of the hands, very clearly of the right. This is very classic hemichoria. Now the age gives you an idea. A young boy with hemichoria, we should think of rheumatic heart disease. This is the classic St. Vitus dance that we all talk about. It is mostly bilateral, but 30% of the cases can be unilateral. And the echocardiography would lead to a diagnosis. The patient had RHD, and treatment would be penicillin. So such kind of initial managements can be done at physician level if we look at the movement disorder closely. Chronic history, we have time to observe. If we have a tremor patient with a chronic history, the Parkinson's essential and dystonic tremors, you can try to differentiate them. Parkinsonism, resting tremors is very important to identify. My previous speakers already told about it. The red flags need to be identified. Dystonia, the initial things should be childhood onset or adult onset. Childhood onset, more genetic causes would be there. Chorea, the onset acute would be more metabolic, and familial history for chronic causes, Huntington's, etc. Myoclonus neo onset is something that we encounter a lot in ICUs. So ICU, the neo onset myoclonic jerks can be all metabolic because of uremic encaps, because of hyponatremia and other encephalopathies. And epilepsy might be associated, so GTCS and other histories has to be taken. Tics, childhood onset and changing patterns over time. This is something that we need to observe. And dyskinesias, we need to observe about the drugs. So talking again about the history for a physician, relevant current and past medications are very, very important to talk about. So this patient, if we closely observe these movements, there are a lot of facial movements that the patient is. He's very restless. Akathisia or restlessness is there, and a lot of facial movements associated. So as soon as we ask about the current medications, he took out a Pantoside L, levosulpiride, and that was most likely the cause of his dyskinesia. So these orofacial dyskinesias that Dr. Sahil pointed out are very common in these patients. So we have to remove this medicine in this case. Another patient who had just an injection of metoclopramide. So injection perinom was given in a small setup, and his eyes went up. So oculogyric crisis and acute dystonia can be sometimes a cause. And there the drug that needs to be removed is a metoclopramide. So drug-induced movement disorders, I think physicians can see if the patient is on antipsychotics, metoclopramide, levosulpiride, amisulpiride, and Stemetel is a very commonly used drug. Even flunarizine and cinarizine, if taken for prolonged periods, can cause both kind of movement disorders, both hyperkinetic as well as hypokinetic. The gross phenomenology and management options for tremors, there are subtle things that we need to test for Parkinsonian and essential tremors, but the most important thing is the resting tremor. The drug that has to be attempted is levodopa, and for other tremors, propranolol, primidone can be used for initial times. This is a very good example of observing the resting tremors. If we see the resting tremors in the initial period, we can just offer the patient a dopamine. A Syndopa tablet made this difference in just 25 minutes. So resting tremors have to be observed, and this was tremor-dominant Parkinson's disease. The drug to be offered is Syndopa. We already talked. This is a good dopamine observed. The period where myopia has severe, is getting up and walking is very slow. And this is after 1 tablet of Syndopa. So a very good response to dopamine replacement. I think this is important for all of us physicians, how to use the magic wand. So levodopa, carbidopa comes in two preparations. One is an immediate release preparation, which is 100, 110. Syndopa 110 is 100 by 10. One is 125 and 275, where there are various combinations of levodopa and carbidopa. The second combinations are controlled release, Syndopa CR formulation, where we have 25 and 250. And the time to use them, for example, the immediate release tablets are more used in daytime. They are given at fixed timings. We generally keep them pre-meals. For example, we can give it at 8 o'clock, 1 o'clock, 6 o'clock, or a 7 o'clock, 11 o'clock, 3 o'clock, such as timings. And constipation is something that needs to be tablets are mostly used in night time, and there are slow release and longer action of these tablets. So magic wand has to be used in a better fashion. And what are the common adverse effects of the? I think as physicians, propranolol, primidone, pacitane or trihexyphenidyl, baclofen, clonazepam, and tetrabenazine. So propranolol is used for tremors at doses of 20 to 320 mg per day. The side effects can be bradycardia, hypertension, and it can mask hypoglycemia. Primidone can be used at 25 to 750 mg per day. Sedation, tolerance, and lupus reactions are common. THP is used for tremors at 2 to 40 mg, and side effects are very common. So dry mouth is very common, constipation, and cognitive decline, especially in elderly. So elderly patients should be tried to be kept off trihexyphenidyl as far as possible. Baclofen can be used for dystonia and spasticity at 25 to 120 mg per day, and sedation and falls can be caused because of hypertonia. Clonazepam is used in dystonia and RBDs for Parkinson's at 0.5 to 6 mg per day, and sedation and tolerance, we all know, is a problem with it. And tetrabenazine is used for chorea at 12.5 to 100 mg per day, but depression, suicidal issues, and sedation are major issues. And the other drugs used for Parkinson disease include COMT inhibitors, dopa carboxylase inhibitors, dopamine agonists, and others. The two groups that I would like to discuss, one is dopamine agonists. So pramipexoles and ropinirole can cause orthostatic hypotension, hallucinations, and acute somnolence. So these common side effects need to be understood. And similarly, levodopa can cause in higher doses hallucinations, nausea, and postural hypotension. Other side effects we have already talked about, trihexyphenidyl. So these drugs and side effects need to be pondered upon. And I'll come to my last two slides. Falls in elderly, also physicians, I guess, they are the first people who hear the complaint of an elderly falling. So I hate falling is a mnemonic where the joint tissues, orthostatic hypotension, because every elderly patient, we as movement disorder specialists ask them to take the BP in sitting and standing position. So orthostatic hypotension can be avoided. And tremors and Parkinson's has to be asked about if the patient is falling, do you have any tremors? And sometimes neuropathy is a very important cause of falling in elderly. So diabetic neuropathy has to be tested as well. So these are some common causes of falling. And drugs that need to be removed from the prescription can be sedatives, neuroleptics, benzodiazepines, and sometimes antihypertensive agents, which were used in high doses, which can cause orthostatic hypotension. And as we finish off my PPT, we still are missing the most common movement disorder. So we are talking about restless leg syndrome. So RLS or restless leg syndrome is another very common thing that comes to the physicians, where patients say that they have nocturnal or nighttime pulling of feet, or feeling of paresthesias or throbbing sensations. So these patients need to be worked upon for ferritin, iron, B12, and uremia. So these are the most common causes of RLS. Drugs to treat are dopamine agonists and gabapentin. And very importantly, we are very commonly seeing patients on drugs like Nexito or escitalopram. So SSRIs can aggravate RLS, and that have to be removed from the prescription. Thank you everyone for patient listening. And there is a movement disorder here as well. So this is a moving ear syndrome. Again, a psychogenic, a functional movement disorder, and Botox can be given for this as well. So these, my tribute to my parent institutes, SMS Hospital in Jaipur and Jaslo. and to my mentor for everything I am now. Thank you.
Excellent talk, Vaibhav. It was really great talk. And I think what Vaibhav has highlighted very nicely in his talk, the drug-induced movement disorder, he has time and again repeatedly, he has emphasized and re-emphasized. So that is something which probably many of the physicians will be seeing regularly. So they should keep an eye for these movement disorders. And of course, he has covered an entire set of other things also, which the physician can gain knowledge for. So next, after Vaibhav, the fourth talk will be on when to refer a patient to a movement disorder specialist. So a physician who is taking care of a patient and who sees a patient movement disorder. So Vaibhav has very nicely told like what to do when you see it first time. So now Dr. Divya, my co-host, she will be speaking on when to refer a patient of movement disorder to a movement disorder specialist. So Divya has several publications to her name, and she is additional professor neurology at Sri Chitra, and she is working wonderfully in the field of movement disorder. So Divya, please go ahead with your talk. Divya, please.
Yeah. Thank you, sir, for the kind words. So I think Vaibhav has very well explained what is the role of a physician or a psychiatrist in the identification and management of movement disorders. And after recognizing all the phenomenology which has been discussed prior to this, so let us see when we should refer to a movement disorder specialist. So when I say this, everybody would be wondering, what does the movement disorder guy actually do? I'll be just running through a few cases which will show you what, in addition, will be or can be done by a movement disorder specialist. So let's run you through a few cases. This is a 60-year-old man who presented with tremors, slowness, and stiffness. So the diagnosis is quite obvious. So there is significant bradykinesia. There was rest tremor. You can see a left lower limb dystonia that is there. This is a case of Parkinson's disease. So obviously, we know that the patient can be treated by the physician as well. So when the patient is started on dopaminergic drugs and the patient starts developing motor fluctuation that needs to be recognized, so you know that as the disease progresses, the patient goes in for motor fluctuations and he needs definite advanced treatment. So this is the person in the off state, which we call that is without medications. And this is the patient in the on state, which is with the dopaminergic medication, especially levodopa. You can see that the patient is having a very good benefit. There's no rest tremor. Bradykinesia is improved. And he is doing well. So this is a patient who has Parkinson's disease with motor fluctuations. And then as the disease progresses, we know whenever the patient is started initially on dopaminergic treatment in the initial 5 to 10 years, he has a significant benefit. And then he starts developing motor complications, like the motor fluctuations. The patient has an effect with the drug. Without the drug, the patient is disabled. And then he starts having dance-like movements, which are called the dyskinesias. And then we have to give the patient the second line of treatment. We need not actually wait. The patient is really disabled by these symptoms. That is where the role of medical management followed by deep brain stimulation comes into effect. So what is deep brain stimulation? This is a surgery which is done for movement disorders, especially Parkinson's disease most commonly. So you can see that this is a lady who has Parkinson's disease. She's almost 13 years into the illness. You can see that the patient has tremors. She has bradykinesia and she's significantly disabled. She needs help to be move out of the chair. And then when she is given levodopa, you can see that the bradykinesia improves. However, she has significant disabling dyskinesias, which are especially affecting the lower limb here. So this is a patient who is having very disabling dyskinesias as well as motor fluctuations. So what does deep brain stimulation do? This is a surgery which is done for Parkinson's disease who are responsive to medication. So the tremor significantly improves after deep brain stimulation. You can see this is a patient with Parkinson's disease without the drug, and this is the same patient after the surgery in the drug off. That is without the drug, with the stimulation on for deep brain stimulation surgery. You see this is the improvement that is with the surgery. The tremor has a significant improvement with deep brain stimulation. Again, this is the patient, you can see the second patient. This is a patient who has significant bradykinesia and rigidity. This is without the drug. You see the patient is severely disabled. Rest tremors, the patient is wheelchair bound. And then on the right, he has undergone deep brain stimulation surgery. And this is without the medication, with the DBS on. You see that her bradykinesia has improved. You can see there are no rest tremors. Rigidity has also improved on examination. And here you see her in the wheelchair, and here you see how she's able to get up on her own. She's able to ambulate. It definitely improves the quality of life. That is, the quality of life is what is extended by the deep brain stimulation. So this is the first patient I had shown. So she had significant dyskinesias in the on stage, and you can see that this is the same patient post deep brain stimulation. This is without the medication itself. You can see that she is wonderfully ambulant, no stiffness and tremors. So deep brain stimulation is a surgery which is done for Parkinson's disease and many other movement disorder conditions, but most commonly done for Parkinson's disease. So this is, we have the leads in the brain and some stimulator which is kept outside over the chest. So this is a surgery which helps patients. And of course, the medical management definitely has a role. And then there is deep brain stimulation which is available. So we know that in long term, the patients have a good quality of life with deep brain stimulation. So this is another patient. He's a 12-year-old boy who presented with dystonia. So as Lulu has extensively showed and in the videos how a dystonia is present, and you can see here that this boy had a generalized dystonia. You can see the severe trunk dystonia, and in a moment you can see how he walks. There's a severe truncal dystonia. You see how he walks. He was tried on medical management, including levodopa. It did not work. He did not have any improvement. And this is post deep brain stimulation. So this is a dystonia which has an exquisite responsiveness to deep brain stimulation. You can see him. This is post deep brain stimulation. So this is a DBS for torsin-1 or the DYT1 mutation. So they have excellent improvement with deep brain stimulation. So this is another boy. He's a 7-year-old boy. Posturing of the neck. So he says that he has these kind of posturing of the neck whenever he has fever or when he is tired. He has no headache. So what is this? It looks like a dystonia, especially in this scenario, but this is just a benign torticollis of migraine. So he does not have any headache. His mother has a strong history of migraine. And we need to also rule out mimics of dystonia. So this is just a benign torticollis of migraine. He was given flunarizine and he completely improved. He did not have further episodes. So this is another patient who has a chorea. You can see there is a significant chorea. This was predominantly over the right side. And then she has the milkmaid sign. She also had the jack-in-the-box tongue. This is a generalized chorea. She had a past history of stroke. She's just 18. She had a past history of stroke at 14 years of age. It's important to recognize the movement disorder and also to look at the past history. You can see that there are infarcts which are there. There's a hemispheric atrophy. This is immune-mediated chorea. This is she was positive for APLA. And this is a APLA-associated chorea. So phenomenology and etiology needs to be recognized. Now, this is another lady who has traumas for the past 6 months. You can see that he has a tremor which comes. So he was diagnosed as essential tremor. But is it really essential tremor? So she was tried on multiple medications for essential tremor, including propranolol. And then So you can look at her face. That's the clue. Does she look depressed to you? So we ask her to tap the left upper limb. The tremor is predominantly in the right upper limb. We ask her to tap with the left upper limb. Then you see the tremor stops. So essential tremor does not stop like that. So this is functional tremor. This was extractable. So it can just mimic an essential tremor. So this is just a functional tremor that was seen in this patient. So this is a 17-year-old boy who has these disorders from around 7 years of age. It was waxing and waning. So he was being treated by a psychiatrist because he had behavioral issues as well. He was always restless, and you can see muttering. He keeps making sounds like this. He was never identified to have a movement disorder. He was thought to have psychiatric symptoms. So he had jumping, restlessness. So this is a patient with a very drug refractory Tourette syndrome. So you can see in the first video, we tried him on all the first and second line medications. It was very much refractory. He used to respond in the initial few days. And you see, he's still restless. He just cannot sit. He keeps howling at school. So we had to take him up for a deep brain stimulation surgery. And you can see him, this is 2 weeks post-surgery. His motor tics have significantly improved. He occasionally has some hushing kind of voices, but he has a significant improvement in his symptoms post-DBS. So let's run you through short cases. This is the patient who was on D2 blockers. So she had this kind of abnormal movements of the tongue. She was hardly able to speak. So you can see that her tongue is never at rest. Just keeps moving. So what's that? This was a tardive dyskinesia, and this is we treated her with botulinum toxin injection.
Medical College. Padmanabha Swami Kshetram. Padmanabha Swami Kshetram.
She had significant improvement with botulinum toxin injection. You can see she could speak very well. And the movements have disappeared. So this is a case of hemifacial spasm. You can see she was embarrassed by these kind of movements and the deviation of the angle of the mouth. And first line management is botulinum toxin injection. You can see that she has an excellent improvement post botulinum toxin injection. She is no more embarrassed and can go for her work. So this is another patient who had tics. He was anxious, and whenever he was to go for any job interview, he was severely disabled by this. And because it was very focal, he was not responding to medications. Because it was very focal, we gave him botulinum toxin injection. And you can see that, yeah, this is not a still, he's moving. You can hardly see that there are any hyperlinks here. So he had a significant improvement with that. And this is another patient who had an early childhood stroke and a post-stroke dystonia. You can see that the right upper limb is severely dystonic. And she started writing with her left upper limb because the right upper limb was dystonic. And this is again with botulinum toxin injection. You can see that she has a significant improvement. The same you can see for patients with post-stroke spasticity. The improvement may not be this robust, but definitely the patients who have significant spasticity can be referred for botulinum toxin. And this is a cerebral palsy kid who has a lower limb spasticity and is hardly able to walk. And this is after 2 doses of botulinum toxin and physiotherapy. You can see that he is able to walk without support. So in patients with post-stroke spasticity with a cerebral palsy, so these are patients where we can go for a botulinum toxin injection and can help reduce spasticity. So this is a patient who had a very subtle movement disorder. You can see that he has just a twitching movement of the arm, which can very easily be missed. So like NMDA, this is another autoimmune movement disorder, which is called the LGI1 encephalitis or the VGKFC encephalitis, where you see these kind of facial-brachial dystonic movements which can be seen. So these are small seizures. And once again, like Vaibhav showed you, this is a patient who has a very common movement disorder. This is a sleep-related movement disorder. It can sometimes be very severe, or many a time most often it is subtle. This is a patient who had severe restless leg syndrome. He was not really responsive to most of the medications, RFT or ferritin, everything was normal. And this is a patient, we had started her on PEM panel finally, and you can see that in the night she was doing well. She could walk normally, she could sleep peacefully. So that's the improvement she had. To conclude, the core of diagnosis in movement disorders is always pattern recognition. A good history and phenomenology may point towards the etiology. And there's a growing importance, especially for the physician and psychiatrist who see the patient first, to recognize these movement disorders, to treat them when possible, and refer them when necessary. It's always a teamwork. So each person in the team is, as always, important. Thank you very much.
Thank you, Divya. It was an excellent talk, and you had very nicely summarized the high-end treatment which can be provided at a movement disorder center. So I think this brings us to the end of all the 4 talks, and I just wanted to just summarize, like in the talk 1, Dr. Sahil has very nicely shown about all the movement disorders which we can see or a physician can encounter, and that time it is he has very nicely shown the different phenomenologies. The phenomenologies are very important so that you can diagnose once the phenomenology, then very nicely showed how to diagnose movement disorder for a physician, and the diagnosis is pretty much clinical, as he said, of course, with some investigations to support. And then he has said a very nice take-home message that any young patient with any movement disorder abnormality, please suspect Wilson's disease. This is very important because it is a treatable disorder. The third talk, Dr. Vaibhav has shown that what a physician can do when he encounters a movement disorder patient for the first time. And again, what he has highlighted was that there are some disorders like drug-induced movement disorders and metabolic movement disorders and some infection-related movement disorders, which physicians can pretty much diagnose and tackle. And of course, they can diagnose and tackle Parkinson's disease and other initial disorders in their initial phases. And then Divya has very nicely said about when to refer to the patient and for the high-end therapy of movement disorders, and she has shown what a proper injection of botulinum toxin and what deep brain stimulation can do and how it can improve the quality of life. So I think probably with this we will see if there are any questions from the audience. Then our experts are open to it, and if not, then I will request Divya that she can introduce the panelists, and we can go ahead with the panel discussion.
So there is a question, orthostatic trauma, how do you diagnose and how do you treat? Dr. Neeraj, would you like to?
Hello. So orthostatic tremor is something which probably, as the name suggests, so a patient usually will have tremor when he's standing, and then once they walk, once they are sitting, then it is they're fine. So on prolonged standing, sometimes like they are standing in the queue or they are standing on a bus stop, things like that. And then the diagnosis is something which probably you can do clinically. You can number one, when you can say the patient to just stand for some duration, and then you can in fact see, you can feel, and in fact even you can hear it through a stethoscope. And then, of course, is the electrophysiology, which we do for tremor, which I think we already have Dr. Sanjay. If he will be around, then he's doing a very good job in electrophysiology of tremor. And there we can see the tremor of 14 to 16 hertz tremor and the tremerogram. And these things will help us to diagnose patient of orthostatic tremor. Yes. Anything else is there, Divya?
No. Dr.
So
Mallikarjun, do
can
you have anything to say? You have raised your hand. Okay. I think that ends
so
the
maybe
question.
Dr. Divya can introduce the panelists. We have the 4 panelists for the day.
Yeah. So finally, we come to panel discussion. So we'll just run through a few questions to clear the doubts. For the panel discussion, we have 4 expert panelists. The first one, Dr. Achal Kumar Srivastava. He's a professor of clinical neurophysiology in the Department of Neurology, All India Institute of Medical Sciences, New Delhi. His areas of interest are ataxia. He's known for his research and talks on ataxia. He's also interested in epilepsy and genetics of movement disorders. He has multiple achievements to his credit. The second panelist is Dr. Sanjay Pandey. He's a renowned neurologist and tremor specialist. He's the professor and head Department of Neurology and Stroke Medicine at Amrita Institute of Medical Sciences, Faridabad. His areas of interest are neurology, stroke medicine, botulinum toxin, dystonia, and tremor. And he has multiple achievements to his credit. The third panelist is Dr. Ravi Yadav. He's the professor, Department of Neurology, NIMHANS, Bengaluru. His areas of interest are Parkinson's disease and movement disorders and sleep medicine. And he as well has multiple achievements to his credit. The final panelist, we have Dr. Ajit Cherian. He is the additional professor of neurology, Sri Chitra Tirunal Institute of Medical Sciences and Technology. His areas of interest are movement disorder, epilepsy, headache, and electrophysiology. And he has multiple publications to his credit and has multiple achievements. So to move on to the panel discussion, Dr. Neeraj.
Yes. So Achal sir is there. Dr. Achal is there, no, sir?
Yes.
Achal
Neeraj,
sir?
I'm there, Neeraj.
So welcome, sir.
Thank you.
Welcome,
Thank you.
sir. So,
Thank you.
I think Divya has prepared very nice questions, which very commonly are encountered by a physician. So, the first question which we wanted your thoughts on is suppose a physician who wants to know that how can I diagnose a patient of Parkinson's disease? First part, and second part, if suppose I have a suspicion then of a Parkinson's disease, then do I refer?
I think Divya has to ask the question.
Sir, can you hear me, sir? The question
Yes,
is,
I can.
yeah, that
I think the question is how to diagnose and when to refer. That's what?
Yeah.
Yes, sir.
Yeah,
Yes,
okay.
sir.
Okay, all right. So I think how to diagnose, we discussed a lot, but still I would like to tell again. As you all know that it's a disease where there is a tremor, rigidity, postural instability, and of course these things have to be in different combinations. Sometimes tremor is very prominent, sometimes rigidity is very prominent. So what happens if these features are there in a particular patient, then you can of course make a diagnosis of Parkinson's disease, or sometimes you may put a possibility of Parkinsonism. As you all know that idiopathic Parkinson's disease is a different or definite kind of syndrome where you can of course diagnose clinically. It's a clinical diagnosis, and then go ahead with imaging of the brain. And again, it depends where are you practicing, in which area of the country, where which kind of imaging is available. Only CT is available or MRI is available. You can go ahead according to the availability of investigative facility in the city. And then of course the first line, you all know, the first line dopamine agonist, and in some of the patient, depending on age of the patient, you can also give trihexyphenidyl, but of course dopamine agonist is the first line therapy. The question is whether to start all this as soon as you see the case. Yes, you can. Again, it depends on in which area of the country you are practicing. Um, is there medicine available in many parts of the country? I have actually visited and found that the most frequently used drug Syndopa is not available. And of course, forget trihexyphenidyl and all those things. Recently, I was in an area where none of the Parkinsonian medication was available in that particular part. So accordingly, it depends on where are you practicing. But at the same time, there is one more clue to it, like one more problem to it is that whether the patient can go to a hair center. On many occasions, you will find that patient is unable, no money to go to a hair center, and even no money to go to city. So in those cases, of course, depending on availability in the area where you are practicing, you can of course start the medication. I will one thing like to point out that trihexyphenidyl you should not try in patients who are beyond 50-year age. Should avoid in all circumstances. Of course, there are definite contraindications to pacitine or trihexyphenidyl. You should not give, and if you are aware, then it is all right. Otherwise, in older age patient, you should not try. Younger age patient, you can try. So these are scenarios. If you ask me, I will say yes, send all patients to neurologist. But at the same time, as I said, that in what area you are practicing, you should work accordingly. You should work for the benefit of the patient and not refer all patients to the hair center. Try to manage if the patient is unable to move out. Otherwise, if you don't feel comfortable, again refer the patient to a hair center or to a neurologist practicing in your area or to a tertiary care center where the movement disorder clinic is there. So this is my idea. I mean, of course, people can have different suggestions. This is my idea how to go ahead with a patient of Parkinson's disease.
Thank you. Thank you, sir. Thank you, sir. So, one more question which a physician can ask himself that what are the different therapies available for patients with Parkinson's disease? And as you said, medications. So, what are the advanced therapies, sir, which a patient can get, a patient of Parkinson's disease can get, sir?
So, of course, many of our medicine colleagues must be knowing about deep brain stimulation. That is one. And then, of course, there is a now availability of MRI guided focused ultrasound in, I mean, very one center is working. Otherwise, in other countries, it is, yes, available. And then there are two more options: continuous levodopa, carbidopa, intestinal gel, and the other one is continuous subcutaneous epomorphine infusion. These are some advanced therapies. Of course, these therapies can't be practiced in every part of country, and moreover, I will suggest that these are, of course, options to know, but these should be practiced in movement disorder setting or in a tertiary care center or whatever centers who are practicing movement disorders can go ahead with this kind of therapy. I will not suggest that physicians should be working on these advanced therapies which I told.
Thank you, sir. So I think sir has made it very clear, and as well as the talks, the four speakers were nicely given the talk that you can diagnose clinically Parkinson's disease, and if you have any suspicion, immediately refer to neurologist or to movement disorder specialist. And if you feel that it is definitely Parkinson's disease, then you can start with the dopaminergic agents like levodopa, dopamine agonist. And of course, I would again request all the physician friends to again please rule out any other drugs which the patient is taking depending on the duration of Parkinsonism, as sir and other people also have highlighted. So before you start all these things. And second thing, again, sir has very nicely said that for any advanced therapy, you immediately send the patient to the neurologist or movement disorder specialist. So thank you, sir, for enlightening us. And next, I think Dr. Ravi Boss is there.
Yeah, I'm there. Yes.
So Dr. Ravi Boss, I think sometimes physicians, as a physician, they may think that what common things which I can do for the patient. So they may think that, okay, I may do some diet modifications or I may suggest some exercise to the patients. So how do you explain about to them that about the diet and exercise role of these two things in treatment of patients with Parkinson's disease.
Yeah, thank you, Neeraj. That is a very important thing which actually at any level of healthcare can be done. So, as the first thing is the exercise, because many of the patients may present with frozen shoulder or pain in different parts of the body, stiffness, and various studies have shown that actually the good exercise can actually overcome many of these things. And initially, there may be some guidance required about how much is the amount of exercise which is required based on the cardiac condition of the patient. If the cardiac fitness is there, then obviously walking, so aerobic exercises, joint related exercises where mobility is one priority. And to achieve mobility, especially yoga uh, exercises which are not very, which do not within the limits of mobility should be done under supervision to begin with. But once all these, for example, in frozen shoulder, for example, severe pain may be there. So initial dopaminergic therapy is given, and then subsequently the exercises and physiotherapy is done. But overall, even it has been found that running, jogging, playing badminton, or active any other games can be pursued without any problem. But it has been seen that it is if it is done in the on state or when dopaminergic therapy is instituted, then the patients are able to tolerate it better. Number two is about the diet. So diet, we always say in our country that the green vegetables, colored fruits, antioxidant containing colored or seasonal fruits like orange, papaya should be important part of the diet, as well as the roughage inducing green vegetables, which can help in relieving constipation. Probiotics also have been found to have significant role in improving the non-motor symptoms of Parkinsonian syndromes. So these are the broad headings, but it has to be individualized because diet will, if there is coexisting diabetes or untreated hypertension, then it has to be supervised. But broadly, these are the things which which can be advised at the level if the cardiac fitness is there as well as diabetes is also being managed adequately. So that is my opinion. Yeah.
Thank you, boss. Very well explained. So another question which I wanted your thoughts on is like a physician, when now that they know that the water movement disorders, they will diagnose them. Then when should they suspect secondary causes of movement disorders? So that if you can give some light on this topic, please.
I think Vaibhav showed very nicely some of the videos like what they encounter in the emergency setting. So hyperglycemia is very important to see. When uncontrolled diabetes is there, then there can be severe chorea, bellesmus kind of movements. Also with calcium abnormalities, which is seen in ICU settings, hypocalcemia, hypercalcemia can present with the involuntary movements. Then hyponatremia severe, for example, can lead to pontine demyelination, osmotic demyelination, and lead to Parkinsonian features. And then other things are that even any other abnormal, like for example, copper-related, liver-related, chronic liver disease patients, if they are seen, they can present with Parkinsonian features. And MRI can show manganese deposition in such cases. So chronic liver disease. So they may improve with low dopaminergic drugs. So they secondary causes have to be because neurology is actually built on medicine. So a good physician will be able to diagnose and then try to correlate the association with some of these involuntary movements. For example, as I told you, common ones are glucose related, calcium related, ammonia related, or even liver failure related. And so these should be commonly looked at in the physician setting. But otherwise, also identifying basically slowness or hyperkinetic, and then associate with the reports which patient has got. Even polycythemia, for example, can lead to chorea for that matter. Yeah.
Thank you. Thank you, boss. Very well explained, boss, because this is what actually Dr. Ravi was saying, that if there is any systemic disorder, and or if the patient is on any drugs or any other things
Yes.
which the patient is doing, and
Yes.
patient has developed movement disorder suddenly, then always try to link them, and that way it will help us to diagnose a secondary movement disorder.
Another small thing, always review the prescription. Like we always try to look at
Yes.
levosulpride, antacids.
Yes.
So reviewing the prescription is very significant. Sometimes haloperidol, all these drugs are given inadvertently for some kind of sleep disorder, and that can lead to lot of complications.
Yes.
Thank you.
Thank you. Thank you. Thank you, boss. So I think now I will hand over to Dr. Divya, and Divya can take over and probably can proceed further with the panel discussion. Please, Divya, please.
Yeah, thank you, sir. Dr. Ajit, I would like to know, can drugs cause movement disorders? Yes, we have been discussing quite a lot on that. So when do you suspect that it is a drug that is causing the movement disorder, or how do you identify drug induced movement disorders?
Okay, there are multiple drugs which can cause movement disorder. I think the most commonly used or most commonly encountered drug will be D2 blockers. So all sorts of antipsychotics can cause movement disorders, except maybe perhaps the most selective like clozapine and the newest one like pimavanserin. Rest all are notorious to cause. The older generation drugs are more common to cause rather than the newer generation. And prokinetic drugs like metoclopramide and levosulpride are also known to cause drug-induced movement disorder. So what can they cause? And how do you identify? They can cause acute dystonic reaction as well as relatively late onset dystonia. And how to identify is they are predominantly periorally and midline or axial in distribution. They can have perioral movements like we had shown one lingual D2 blocker induced lingual dystonia, which was improved with botulinum toxin, as well as retrocollis and axial involvement. So retrocollis is very, very characteristic, and opistotonic posturing. So these are also very characteristic of drug-induced movement disorders. So coming to other drug-induced disorders, you can have drug-induced Parkinsonism. Again, the culprit is often D2 blockers. You can also have it secondary to calcium channel blockers like clonazepam. Drugs which are given for Meniere's disease like Stugenol Plus, which is a combination of cinnarizine with diphenhydramine maleate, and as well as sodium valproate. So these can cause drug-induced Parkinsonism. Other subgroups are drug-induced tremors, and the most common or notorious drugs which can cause are steroids, sodium valproate, tacrolimus, lithium, and cyclosporin. So these are the most common drugs which can cause. So one needs to go through the prescription and have a careful look before we jump to any conclusion. And many a time, shifting from one of these inducing agents can itself be a curative for the individual. And one needs to know that the certain Siddha Unani medicines can cause autoimmune movement disorder, especially Caspar-2 antibody-induced movement disorders have been precipitated or provoked by certain heavy metal components in the Siddha Unani medication. So one needs to be aware of this entity. Pacitine usually in the elderly can cause a very peculiar orolingual dyskinesia, which is more of a coriform in nature. And even without seeing, by hearing itself, we can figure out this Pacitine-induced orolingual dyskinesia. And other drug of abuse like cocaine can cause similar sucking coriform movements. And people who have been using MDMA can also cause this kind of perioral dyskinesia. So these are some of the things one should be aware about. Thank you.
One more question, Dr. Ajit. We commonly see that most of whenever patients are on D2 blockers or antipsychotics, they are given trihexyphenidyl in combination, or we have multiple combination drugs with trihexyphenidyl. So is there any role for adding anticholinergic, or should all patients be given trihexyphenidyl with D2 blockers or antipsychotics? Because that is one of the most prescribed drugs, the combination of D2 blocker with anticholinergic.
Okay, there is no rationale for combining trihexyphenidyl initially with the D2 blocker, because Of all, even though D2 blockers can cause Parkinsonism as well as drug-induced movement disorder, there is only a very limited. Suppose if you give to 100, less than one third may actually go into these complications. So you are unnecessarily exposing rest 75% to 80% of the individuals otherwise. So there is no rationale in combining trihexyphenidyl initially itself when you're giving a D2 blocker. So you can give a D2 blocker, and some of them maybe in the long run may develop tremors or some other movement disorder. So especially if they develop tremor, you may add trihexyphenidyl to those who develop tremors due to a D2 blocker, and you are in a soup where you cannot withdraw D2 blocker because the psychiatric condition is very well controlled with that. So you are at in a dilemma whether reducing the dose of the D2 blocker may precipitate his psychiatric condition. So in that situation, so at a later stage, you are justifying adding a trihexyphenidyl. So there is no rationale in straight away. So at the onset itself, in combining a D2 blocker with a trihexyphenidyl, and one will precipitate or aggravate the memory impairment because patients who have been exposed to long-term pacitane or trihexyphenidyl are known to have significant memory impairment during the course of their illness. So one should not expose unnecessarily any individual to any unnecessary medication. So that should be the take home.
Thank you, sir, for highlighting the point on trihexyphenidyl. It's a very important and relevant point. So, Dr. Sanjay Pandey, sir, could you please highlight on what are the treatment options which are available for dystonia currently?
So, dystonia treatment is oral medication, botulinum toxin, and surgical management. So, for focal dystonia, you can start with oral medication, like you can start with anticholinergic drugs, like trihexyphenidyl, clonazepam, and sometime patient may also respond to baclofen and tetrabenazine. But for focal dystonia, majority of the time these drugs don't work well. So you start straight away with botulinum toxin. And botulinum toxin is very effective. And uh, other other options are surgical options, because in generalized dystonia, it's very difficult to keep on injecting botulinum toxin for a long period of time because the doses are very high. So if it is a generalized dystonia, primary generalized dystonia or gene-related dystonia, it's better to go ahead with deep brain stimulation because the results are good. So the treatment option of dystonia will depend upon what is the uh, spread of the dystonia. Is it focal or is it generalized? In secondary dystonia, like we see in pediatric patients, secondary to hypoxic injury or sometime post-stroke dystonia or infection-related dystonia, the management remains same. Uh, if it is a focal dystonia, we give botulinum toxin straight away. If it is a generalized dystonia, maybe we can start with medication because DBS doesn't work well in secondary dystonia, secondary generalized dystonia. So these are the treatment options for management of dystonia.
Thank you, sir. So you highlighted that botulinum toxin injection is one of the very important treatment options for dystonia. So what is the role of botulinum toxin injection in the treatment of other disorders other than dystonia? Where can we use botulinum toxin?
So botulinum toxin is a very good tool to use in even Parkinson disease patient. Like we use botulinum toxin for camptocormia, we use for striatal hand deformity, striatal foot deformity, we use for drooling of saliva like siluria. A lot of Parkinson patient have siluria. In PSP patient, we use lot of botulinum toxin for blepharospasm, apraxia of eyelid opening, and sometimes these patients have neck dystonia, like a lot of PSP patients have retrocolis, and they really improve a lot with botulinum toxin injection. Other movement disorder where botulinum toxin can be used is tics. For focal tics, botulinum toxin is a very, very good option. And one of the questions you have written regarding headache and pain. So headache and pain, they are not movement disorder, but one pain I will like to precisely is trigeminal neuralgia, because trigeminal neuralgia is, if you see the name of trigeminal neuralgia, it's tic dolor X. And these patients also respond very well to botulinum toxin if the pain is refractory to other medications. So botulinum toxin has a very important role to play in movement disorders. The best part of botulinum toxin is that the effect is very good, and even if the patient develops some side effects, they are reversible because the effects and side effects wanes over a period of time. So it's an entirely safe therapy if it is administered by the expert and the selection of muscles are good.
Thank you, sir. Yeah, thank you, sir. So with that, we come to the end of the panel discussion. So before we end, there are some questions in the chat box. Dr. Weber, how can a physician handle dopamine doses and hallucinations in Parkinson's patients? Dr. Weber, are you there? Okay, so when a patient is having hallucination in Parkinson's disease, what one needs to understand that many of the time it can be drug induced. So if the patient, especially most of the anti-Parkinsonian medications itself can cause hallucinations. Trihexyphenidyl is notorious to cause. You can have amantadine causing hallucinations. Generally, when we have hallucinations, the dictum is to come down on the drugs which can precipitate, which includes trihexyphenidyl, amantadine, MAO inhibitors, COMT inhibitors, pramipexole in that order, and levodopa, the last, is to come down. So it depends on how bad the hallucinations are. If they are very subtle, you can give them antipsychotics. Please refrain from using any form of D2 blockers, in whether it is risperidone. Haloperidol is a strict no, and other things, even like risperidone, aripiprazole, olanzapine, all these things can worsen Parkinson's disease and Parkinsonism. Hence, these should not be used. The safer ones include quetiapine, clozapine, which have to be started in very low doses as compared to patients with psychiatric diseases. Like generally, quetiapine is given in a dose of 200 to 400, but in most of the Parkinson's disease patient, it is enough to give them something like 12.5, 25, or 50. So usually those doses suffice for patients with Parkinson's disease. Even clozapine in very low doses, and the newer drug which is available, that is pimavanserin, which can also be used for hallucinations and psychosis in Parkinson's disease patients. The next question is, kindly tell the drug I mentioned for restless leg syndrome. So the first treatment is definitely pregabalin, gabapentin. You correct the iron levels, and we had also given the newer drug is perampanel, which has a very excellent improvement in restless leg syndrome. You start at 2 milligram and gradually hike it up at 4 weeks to maybe 4 milligram. The next question was from Dr. Pramod. Are these complications reversible? That is a drug-induced complications. Dr. Ravi, sir, would you like to highlight on that? Are the drug-induced complications reversible after withdrawal of triggering agent?
So, in case of levosulfide, I'll just tell some of my experience. If it is withdrawn early, like some of the patients within 1 or 2 months of onset, early diagnosis and removed, then I have seen that it completely subsides. But in patients who have been on drugs for many years and all, it may reduce definitely once we withdraw drug. But then there is a problem. For example, in tardive dystonia syndromes, even if the drug which has induced that is gone, still it, I think, causes permanent changes, and then they do not improve. But if it is subtle, mild, early diagnosis, early taken out, then mostly they improve. But I have seen that short, brief exposure also to some of these powerful dopamine blockers can actually lead to long-term movement disorders. So it depends probably on the intrinsic capacity of individual, how their metabolism is, how their sensitivity to dopamine blockers is. So it depends on person to, but broadly, early diagnosis, quickly it has to be taken out if any such drug is found. That is any other people, if they have any experience, they can share. But this is what I have found. Yeah.
Yes, sir. So the next question, which Dr. Neeraj, would you like to?
No, actually, I was just trying to add to Dr. Ravi Bose what he said. So sometimes, like these drug-induced movement disorders, they are very notorious. They may persist, and sometimes, especially in drug-induced Parkinsonism, sometimes patients may it may just unmask drug-induced some these drugs, offending drugs. They may sometimes go on and unmask the underlying neurodegenerative. So that is one more thing which probably we usually come across. So otherwise, what Dr. Ravi Bose has said is correct, because many times we don't get the patient to recover completely if there is delay in diagnosing and removing the drugs. Yes, yes.
So there is another question in the chat box, Dr. Ajit. You can take that. Is there a rationale in prescribing Syndopa plus 8 times a day? It was done by the neurologist. So is there a rationale in prescribing Syndopa plus 8?
So in the initial stages of Parkinson's disease, the drug effect may last a very long time. Sometimes you may just need to give it just twice a day. That is because the neurons, the presynaptic neurons, are still there, and then as it's a neurodegenerative process, the duration of the drug closely resembles the T half of the drug. So you reach a stage as the disease progresses, you slowly find that the effect of the drug starts waning off. So initially, if you give, sometimes the effect of the drug may last for 8 to 10 hours or even more. And slowly the duration comes down and down. And slowly it may reach something like 2 hours or less, even less than that. The effect of the drug may be even less than that. So at that point, you can keep like you can have a reduced interval. So you can give it every 6 hourly, every 4 hourly, or even like every 3 hourly. So you are justified in giving, because in the off state, the patient may be so affected, so disabled because of the hypokinesia. So you are justified in giving. So this is because the disease is progressing and the duration of the effect of the drug closely resembles the T half of the drug as the disease progresses. So these are the patients who are likely to, even before this stage, you can slightly shift the patient for a DBS or discussing after discussion. So there is a rationale in prescribing Syndopa 8 times as the disease progresses. No doubt.
Thing is, there's no fixed highest dose or maximum dose that has been advocated, but sometimes the patient himself will overdose levodopa. So that's called the dopa dysregulation syndrome, and you can have significant dyskinesis. That also needs to be evaluated, but when a neurologist usually prescribes, it is with a definite rationale. Sir, Achal sir, there's another question. Status of milk and milk products use, whether to take or not in Parkinson's disease, as a patient asks most of the time, whether milk and milk products can be used with patients.
I mean, why not? They can always use milk product. But one thing they should keep in mind that we always tell everyone, each patient, that the carbidopa levodopa drug has to be taken empty stomach. It works best. That is what. Otherwise, there is no need to prevent anybody from taking milk and milk preparations.
Thank you, sir. The last question, Dr. Sanjay Pandey, sir, could you just take this? How will you manage a drug-induced oculogyric crisis?
Drug-induced oculogyric crisis, stop the drug first. And because what is very, very important to understand, that oculogyric crisis is very immediate to come and very immediate to disappear. But you can try some drugs if the patient is not responding. And but I have seen that most of the patients respond after just stopping the drug.
Thank you, sir. So I think with that, we come to the end of the panel discussion as well as the webinar. So this program was designed basically for our esteemed physicians and psychiatrists who are the most or one of the very important members of this team where we manage patients. And they are the first contact point for most of the patients. And without them, I don't think that the patients can be treated well or can be referred to any specialist for that matter. So it's a teamwork as always. So we had almost 85 attendees today. We thank each one of them for making their time and accepting our invitation, attending this program at this time of the day. I would also like to thank each of the speakers, Dr. Sahil Mehta, Dr. Vaibhav Mathur, Dr. Lulup Sahu, our esteemed guiding members, Dr. Ravi Yadav sir, Dr. Sanjay Pandey sir, our esteemed panelists, Dr. Achal Srivastava, Dr. Sanjay Pandey sir, Dr. Ajit sir, and Dr. Ravi Yadav for making this program interesting and for answering all the questions. And last but not the least, Dr. Neeraj, who was an excellent co-host, being very encouraging as always. Thank you very much.